Assalamu alaikum. We're still waiting for our chair, Dr. Akifullah. He'll be here shortly, but we'll just start with our first talk, which is by Dr. Fahim Al-Hassan. He is a consultant nuclear medicine physician at Guy's and St. Thomas's. And after training in Guy's, he was started a consultant. Now he's working as a clinical lead there. His main clinical interests are radionuclide treatments of endocrine, thyroid, prostate cancers, and also in hybrid imaging. He's actively involved in teaching, clinical research, and is the principal investigator on a number of trials and studies.
Thank you so much for the kind introduction. And first of all, I really need to thank all of you here on online, Hajra, especially you and Humayun, if you are listening, although it will be very early in United Kingdom. And what an amazing symposium you all have arranged. Honestly, this will cost thousands of pounds in England to get registered. So I need to thank all of you, including Aap Sab Kabhi, jo piche behind the scenes, the unsung heroes, the persons, Anika, I don't know whether she is. She has been very patient with my multiple emails. And Nadeem Bhai, Nasir Bhai, who actually got me from airport from Islamabad to Peshawar. This is my first time in Peshawar. And your city is more beautiful than what you are looking at screen. But I work in Guy's, which is just next to the shot. Thank you. So basically, this slide will take a whole day to explain. But why I put it, I just needed to show where is actually the journey of a patient with a prostate cancer. So you start from here, so either surveillance, radiation, surgery, and then the prostate cancer patient, most of the prostate cancer patients pass through one of these stages. And you can see where the lutetium PSMA comes and where the radium comes. I will leave radium for Hajra to explain. And from hormone sensitive and castration resistant prostate cancer, there are few treatments which overlap. At this stage, PSMA is right at this on the right side, but later on during my talk, I will tell you how this PSMA will shift somewhere here and maybe up here. Okay. So it's a prostate-specific membrane antigen is a transmembrane glutamate carboxypeptidase that is highly expressed on prostate cancer cells. Metastatic lesions are PSMA positive, and high PSMA expression itself is an independent biomarker of poor prognosis throughout the course of prostate cancer. I will show this in a figure actually, but PSMA is overexpressed in most prostate cancer cells, including bone metastasis, and the degree of PSMA expression actually correlates with the pathological grade. So on the right side, the top corner, you are seeing gallium PSMA with normal distribution. There is no metastatic disease. So you will have background activity within the salivary gland, low background uptake in the liver and spleen, activity within the kidneys, bowel, and obviously it's excreted through the bladder. On the bottom half of the left side of the screen, these are patients with intense PSMA expression in multiple or innumerable skeletal metastases throughout the appendicular and axial skeleton. So overexpression, pathological grade, hormone refractory, and tumor recurrence, they correlate with each other, the intensity of the PSMA uptake. But remember, nothing is actually a gold standard. So the PSMA expression is low in around 5 to 10% patients of prostate cancers. These are aggressive cancers, non-secretory, neuroendocrine variants, and dedifferentiating disease. And one example is here, a same patient where the PSMA scan doesn't show much PSMA expression, but an FDG PET scan shows multiple skeletal metastases with high metabolic activity. This is also an independent prognostic markers in patients with prostate cancer. The prognosis of this patient is pretty bad. And PSMA should not be given to this kind of patient. Okay, so we have talked about a little bit about the imaging and how it actually then correlates with the therapeutic aspect of it, so into the theranostic. So PSMA is localized on the cell surface as an integral membrane protein. It's then internalized after ligand binding via receptor-mediated endocytosis, and this actually internalization allows the intracellular delivery of the radioisotopes. Okay, how do you compare with the traditional cytotoxic therapies compared to targeted therapies? Now, the traditional cytotoxic therapies, for example, chemotherapies, they attack the cells, including cancer cells and healthy cells. By comparison, the PSMA can provide and does provide selective tumor targeting, aiming to maximize tumor dose and spare the normal tissue. Okay, so therapeutic agents, as we know, work in nuclear medicine, and it's not a rocket science, that you can attach with different ligands. So basically, you have got a beta particles, and then you've got alpha particles. And the use is different. I will just show you towards the end, basically, about the alpha emitters as well. I think no talk of PSMA lutetium actually can be completed without mentioning of alpha emitters as well. Okay, so although we have said that this is a new horizon, in honesty, this is not a new horizon. In mainland Europe, this treatment has been there for years. So I went to a meeting in Society of Nuclear Medicine meeting in St. Antonio in 2015. Okay. So this is 2015. A German professor, Professor Rob, who is a great professor in radionuclide treatment. Actually, at that time, he presented 500 cases of patients who he has treated with PSMA, lutetium with good results. But in modern oncology, no drug is accepted nowadays, especially in the Western world or anywhere, without prospective trials. So the first prospective trial of lutetium PSMA treatment was a Vision trial. Okay, this was published in 2021, so 2 years ago. It was a phase 3 trial where lutetium PSMA plus standard care was compared to standard care alone. The trial was conducted at the 4 sites and Guy's and St. Thomas's. We were also involved. One of the sites was Guy's and St. Thomas's. And what was the primary endpoints? The primary endpoints were imaging-based progression-free survival and overall survival. There were a number of secondary endpoints, which includes but not limited to objective response, disease control, time to first symptomatic skeletal event, safety profile of lutetium PSMA, and health-related questionnaires, and also what were the blood results after giving PSMA therapies, including biomarkers such as PSA response. So 385 patients were assigned to lutetium PSMA plus standard care, and 196 patients were assigned to receive standard care alone. I'm not going to go into all the inclusion criteria or exclusion criteria, but basically these patients must have an adequate performance status. Their life expectancy should have been more than 6 months. All patients must have histological, pathological, or cytological confirmation of prostate cancer and progressive disease. Every single patient had gallium PSMA PET scan positive, and generally the PSMA was offered to patients who had an uptake greater than that of liver background. This was compared to the other study, which I'm going to show you later. No FDG PET scan was mandatory in this case. In every patient, there should be metastatic castration-resistant prostate cancer, so serum testosterone has to be lesser than the castration values. These patients should have received one of the novel androgen axes, so enzalutamide or abiraterone. They must have received previously at least one taxane, so either docetaxel or cabazitaxel, but not more than 2 previous taxane regimes. And they should have an adequate bone marrow reserve. The numbers you can read, but white cell count of more than 2.5, platelets of more than 100, and hemoglobin of more than 9. And these were the values of hepatic functions in patients who had metastasis or Gilbert syndrome. Otherwise, you will exclude patients if they don't fulfill these parameters. Serum creatinine clearances has to be more than 50. So if your patients had epidural disease or spinal canal disease or treated spinal cord compression, these were eligible for the trial. These were the exclusion criteria. So basically, if your patients had previous any of these radionuclide treatments within 6 months of randomization, they were not included. And within 28 days, some chemotherapies and immunotherapies or biological therapies, they were excluded. I'm not going to go through all this. You can read through this. I think the most important thing was that if someone had symptomatic cord compression or clinical or radiological features indicating of impending cord compression, you have to treat cord compression first and then consider PSMA. Okay, so what were the results? What does actually it showed? So the first primary endpoint was image-based progression survival. So it showed that the lutetium PSMA, and along with standard care, was 8.7 months compared to 3.4 months with standard care alone. Overall survival was better. This was about 15.3 months in the blue curve with lutetium PSMA compared to the standard care of 11.3 months. Secondary endpoints were, so among the 248 patients, there was complete response was noted in around 9.2 cases, and none of the groups of the 64 patients in the control group. Partial response was noted in around 42% in lutetium PSMA group and only 3% in the control group. So what was the time to first symptomatic skeletal event? This was 11.5 months. So the patients had fractures or other complications regarding skeleton in much longer time period when they were treated with PSMA compared to the standard care alone, which was around 6.8 months. Okay, the proportion of patients with confirmed decrease in the PSA level who were treated with lutetium PSMA was at least 50% and 80% from baseline were higher in the lutetium group compared to the control group. The time to deterioration in the quality life forms was also favored with lutetium PSMA over the control group. Okay, so the most important thing with any oncological new innovation is what were the adverse events. So on the left side, you can see all grades, and then grade which are more important, more equal or more than grade 3. And this is lutetium PSMA plus standard care alone, and this is only standard care alone. And you can see, and I will just go quickly through the grade 3 because those are most important. And out of grade 3, I think the most important, basically, one, quality of life is fatigue. But you can see basically that around 9%, 6% had grade 3, but around 1.5% in standard care also had grade 3 dry mouth. And the most important probably is anemia, thrombocytopenia, and leukopenia, because these are the usual parameters which either let you to reduce the activity of further cycles of lutetium PSMA, or you have to delay the treatment or stop the treatment. So if you look at these ones, adverse events, basically it's around 1.9% that led to reduction in the lutetium PSMA, around 8% that lead to interruption, and around 4% of these, around 7% of these patients actually led to the discontinuation of PSMA because of myelosuppression generally. The second most important study as far as the lutetium PSMA journey and the prospective journey is concerned is from Professor Michael Hoffman groups in Australia. He did a therapy study in around 200 patients. This was also a randomized phase 2 study. And here, the CRPC progressing patients after docetaxel with gallium PSMA, and they had a very strict and stringent criteria. So they looked at the SUV max of gallium PSMA, and one or more lesions has to be more than 20, and every single patient actually went through FDG PET. So if patients had disease on FDG PET, which was disconcordant, that means that you have got more metabolically active disease on FDG PET compared to low expression in PSMA PET, these patients were excluded. And the activity of the PSMA was also different. So they gave 8 gigabecquerel every 6 weeks up to 6 cycles, decreasing by 0.5 gigabecquerel for each cycle versus cabazitaxel. So cabazitaxel is a well-known drug, very effective drug, needs established in metastatic castration-resistant prostate cancer, and known to know it improves survival. And this was actually a direct comparison between the two. So, and the number is almost equal. So 99 patients in PSMA group and 101 in cabazitaxel. So the primary endpoint in this was the PSA response rate, which was the short abbreviation was PSA 50RR, defined by more than 50% reduction. Lots of patients in cabazitaxel, unfortunately, died before receiving the study treatment. But the PSA was higher in those assigned with lutetium PSMA. So you can say the reduction of more than 50% of PSA was in 66% compared to 37% in cabazitaxel arm. So they followed up these patients for 3 years, or at least we have got the data for 3 years for now. And 3 years follow-up showed that there's a continued favorable response defined by reduction of PSA by 50% or more, occurred in around 66% of the patients who received lutetium PSMA compared to 37% with cabazitaxel. There were also less severe effects, especially grade 3 and 4. As I told you, grade 3 and 4 are mostly the adverse events which leads to reduction, interruption, or stoppage of any PSMA treatment. They occurred in 33% compared to 53% in cabazitaxel. Survival of people assigned to lutetium PSMA was similar to cabazitaxel, which is already a proven lifelong treatment. Median survival was considerably shorter for patients who are excluded in PSMA PET. So as I said to you, the disconcordant disease with FDG PET is an independent prognostic marker. Okay, these are the latest guidelines. I think they're published in 2023. So you must read it if you are treating someone with PSMA. I haven't shown the rest of these guidelines, but they differ slightly from the VISION trial because here they've given you more leniency to treat these patients. So if you remember, the platelets should be more than 100. Here they say if your platelets are or more than 75, you can treat them. And obviously, with any treatment, if your patients are heavily treated before, if they had previously radium, multiple chemotherapies, so the risk of myelosuppression and other side effects increases. I'm not going to go through all the relative indications. You can always read it. It's a good paper. It's a good guidelines to read, actually. So this wonderful thing is not done by me alone or by the nuclear medicine physicians here. So we can't take the credit of all of this, okay? It's a multidisciplinary team meetings or basically members, which is local skill mix. So these patients are complex. So they are always under a prostate oncologist or an oncologist with an interest in prostate cancer. And we as a nuclear medicine specialist, or in England, we call this an RSEC holder. So basically someone who has got an administration certificate of radioactive substance advisory committee. All patients must be discussed in MDM settings. I mean, you can't in 2023 treat the patients on your own. Okay, so the role of operators depends on your own settings, whether you have got a clinical nurse specialist or a trained radiographer or a nuclear medicine technologist who can give this treatment. The role of radiopharmacy is fundamental, but single thing rotates around your patient. Okay, so you have already decided about that you're going to treat this patient, but look at this patient. And that's why I think when you are starting this expensive treatment, and it's very expensive in England, I mean, it's still not approved by the NICE, and I will, the next week is its final appraisal. I think if your meeting was on 21st November, I would have told you that whether it's approved or not, likely it would be, but the one cycle actually will be costing us £20,000. That excludes your all imaging and the rest of it. So if you are giving 6 cycles of something, it has to be NICE looks at the effectiveness of relatively cost effectiveness, basically. So it is, so while we are treating them through the drugs program and through a different channel, so I still do FDG PET in all these patients. And look at this patient. You have got the PSMA expression. So if you have done only gallium PSMA scan, you would treat this patient, wouldn't you? Because you have got PSMA expressions everywhere. But look at the same patient with FDG PET, and you can click. Oops, sorry. Okay, no worries. Should I continue or? Yeah. Okay. Apologies, I wouldn't be able to show those images. Okay. I will wait. Thank you. Okay, so you can see that the thoracic disease, this is all skeletal disease, in proximal femora is all metabolically more active. So this patient is not suitable for PSMA treatment, because if you are only going to give basically myelotoxicity or side effects to this patient, and very expensive side effects also. Okay, so you have done this patient, treated this, and look at the after. I don't think so any other treatment would ever give a partial or a complete response in suitable patients like PSMA treatment does. I mean, this is almost a complete response, except that we would say this is a partial response, because this lesion only shows, which is one of these metastases in the ribs, shows partial PSMA expression. How do we follow them? So this is another patient. So this is cycle 3, complete response. How do we follow these patients? I think that's very important. Now, PSMA PET scan is very expensive, okay? So you need to get on cheaper modalities. So what we do is, and I think probably all nuclear medicine hospitals should do, is a post-therapy scan. So this is what we do is when we treat the patient after 24 hours, some people will bring them in 48 hours, just do a whole body scan and with a SPECT CT. So all our patients get these. So this is a patient who we treated in February 23. You can see there is a humoral met, and this patient is non-secretory. So the PSA was always around 3 and 4, okay? So some patients the PSA wouldn't be that helpful. So, but now look at what has happened after 3rd cycle. So that has disappeared. So there's a complete response here. But unfortunately, you see, the more disease has actually come back after the 3rd cycle. And instead of going into another 6 cycles, if we haven't imaged this patient probably would have not ended very well. So we actually stopped the treatment here and started on cabazitaxel 3 to 4 weeks down the line. So not waited for another, say, about 18 weeks before we can start the treatment. Okay, so this is simple. Like any treatment, you actually see the patient on the day, you make sure that their blood is eligible, a detailed consent form. It's an outpatient treatment, so it's very quick one. Some people will use 500 mils to hydrate them. Some will use 1 liter. Some people will give anti-sickness. You can always give steroids depending upon the burden of the disease, especially if you have got liver metastases along the capsule, or if you think that there can be a neural impingement, you can give them steroids. And the general, what you normally give is 4 milligrams of dexamethasone for 5 days. That's the most common regimen which is used as for as steroids are concerned. Ondansetron is very good if you think your people will be your patient may become have a bit of nausea and vomiting. I'm not going to go through the scientific background because this is all radiopharmacy, because we have got a shortage of time, and obviously you need to have an infrastructure placed. A room along with in-suite will be very good, because lots of your patients have urinary incontinence or have difficulty or urge in micturition, so that will be very good. Quickly, so these are the follow-ups which we normally do. Okay, if you haven't got a PSMA PET scan, do a technetium PSMA inspect. If you haven't had this, but please do post-therapy scans. And remember, when you're doing PSA, so you will get flare response as well. So the PSA, the actual PSA, which you should start following, should be around 2 to 3 weeks after the second cycle. And if from there, if your PSA increases more than 25%, then you should think basically of different imaging modality to make sure that this patient is not progressing while you're treating with lutetium PSMA. And here is the end of those 2 trials. But what is happening now and what is happening in a very near future is that, remember that curve? From the right side, it's now shifting towards the left side in the mid and it. So this is bullseye trial, basically, where they are looking at that PSMA, whether this is an effective treatment in oligometastatic, hormone sensitive. Remember, we have all talked about the castration-resistant process. This is hormone sensitive to prolong the progression-free survival even before the start of an androgen therapy. So basically, this is like first-line treatment and here, okay, rather than actually before even endotherapy in hormone sensitive. Other ones are phase 2 study, which is in combination with the new drugs which we are treating with patients with, and this is castration resistant. The other one is actually cabazitaxel in combination with PSMA in metastatic castration resistant prostate cancers. Few others are phase 2 studies with docetaxel combination versus docetaxel alone, and this is also in hormone sensitive prostate cancer. Enzalutamide with or without PSMA, castration resistant prostate cancer. And last but not the least is LUNAR, a randomized phase 2 study with neoadjuvant. Okay, so this is now in neoadjuvant settings to ablative radiotherapy for oligo recurrent prostate cancer. Okay, one slide only on actinium PSMA. This is an alpha emitter, and this again is a standard treatment in mainland Europe, especially in Germany. Now, I went to one of the talks in ENM and I asked one of the professors, how come you give all these treatments without any regulation? So in Germany, basically, a nuclear medicine consultant can give any treatment as long as he justifies and says this is good for patient. Hooray. So no need of regulations on all these prospective trials, but that only can happen in Germany. Okay, so this is like 6 retrospective studies, 201 patients, and I'm just going to tell you that the pool proportions of overall survival and progressive survival were 12.5 months and 9.1 months. And most of these patients have already been treated with lutetium PSMA, or they have progressed and then they were switched to actinium PSMA. As I said, they have treating it in 2014-15. So look at the PSA 2009-23, and after only 4 cycles, undetectable PSA with a complete response. You can do similar things with bismuth, PSMA up, and basically that's also another alpha emitters. Okay, nearly coming to an Hajar. I know, Akif, you both are looking at your watches. Okay, so what's going to happen? So does the PSMA finishes with hormone sensitive and with castration-resistant prostate cancer? No. So this is an article which was published around 2 years ago, okay? Because as I told you that PSMA is expressed in lots of other tumors. So this is a patient with salivary gland cancer with metastasis. This is a patient with the thyroid cancer with metastasis. This is hepatocellular cancer. And this is breast cancer. So in 3 or 4 years, when probably you will invite a more knowledgeable doctor to talk here about PSMA, they may talk about all these things within PSMA therapies. Thank you so much for listening.
Thank you. The question answer session should be at the end of the presentations, inshallah.
Thank you.
Please. Dr. Hajra will be talking on the radium-223 therapies, outcomes beyond pain management.
Assalamu alaikum, everyone. I'm going to talk about radium, a little bit about what radium is and how it's used, and about our experience using radium when I was at Guy's and St. Thomas's Hospital. So what exactly is radium? It is a calcium bone-seeking analog. What it does is it forms hydroxyapatite complexes at the site of where there's rapid bone turnover, mainly around where the metastases are. It emits ultra short-acting range alpha emitting particles, and it has been shown to prolong survival, and it delays time to symptomatic skeletal events in metastatic castrate-resistant prostate cancer in the LSIMCA trial. So this is the main trial that led to the acceptance and FDA approval of radium. That's the LSIMCA trial. This is phase 3 trial, randomized, double-blinded, placebo-controlled study. They looked at 921 patients. These are patients who were not eligible or who could not, who declined docetaxel treatment. These patients with symptomatic, hormone refractory prostate cancer, and they had skeletal metastases. So they compared the efficacy of best standard of care plus radium-223 versus best standard of care plus placebo. The primary endpoints were overall survival, and the secondary endpoint was time to symptomatic skeletal event. They found there was 30% reduction of risk of death with patients who were treated with radium. The two main points were that the overall survival was increased by 3.6 per month in patients who had radium, where the mean overall survival was 14.9 compared with placebo, where it was 11.3. The secondary endpoint was time to symptomatic skeletal event. This was also prolonged, and in radium it was 15.6, while in placebo was 9.8. This led to the approval of radium by FDA. Other than this, it was found to help with overall quality of life and symptom relief from bone metastases. So who is a suitable candidate? Patients who have castration-resistant prostate cancer, and they've got symptomatic metastases to the bone, no visceral metastases. And they are progressing after at least 2 prior lines of systemic therapy and who are ineligible for any other kind of treatment. How do you measure the progression of disease? They've got a new metastasis if the existing metastasis has increased or there's a rise in PSA. Now, to define the symptomatic bone metastases, this is generally left at discretion of the treating physician, but at least they should have 2 or more skeletal metastases, which is resulting in clinical signs or symptoms, including pain, decreased mobility, impaired function, or fracture. Any metastases which requires intervention like surgery or radiation. Now, what would we classify as visceral metastatic disease? If they've got liver, any other solid organs, lungs, peritoneum, and brain. Soft tissue sites of disease, for example, the prostate bed or bladder wall, and lymph nodes are not considered as visceral. Consultation is initially done with a radiation oncologist, nuclear medicine physician, or radionuclide radiologist. Complete history and physical examination is done first, and it is assessed if the patient at least should have life expectancy more than 6 months prior to starting treatment, and a preferable ECOG performance status of 0 to 2. We also need to assess about where the patient's pains are and reported symptoms, so the quality of life can be assessed before, during, and after the treatment. You have to look at the labs before starting the treatment. Mainly, it's a complete blood count in the month prior to starting the treatment. We also look at PSA and alkaline phosphatase prior to the treatment, on the day of treatment. So for initial treatment with radium, their absolute neutrophil count needs to be more than 1.5, platelets more than 100,000, and hemoglobin more than 10. But for subsequent treatments, lower limits are allowed for absolute neutrophil count of 1, platelets more than 50,000, but there's no set parameters for hemoglobin. For a patient who experiences a decrease in hemoglobin while on radium, a transfusion of red blood cells can be considered at the discretion of the referring and treating clinician. So they need to have imaging because we want to establish if they've got osteoblastic disease. So generally bone scan is done. We also need to do a CT to make sure there's no visceral disease. If they have malignant lymph nodes, up to 3 centimeter shocked axes are still acceptable. So we start with consenting the patients. They're given 6 injections 4 weekly, and the standard administered activity is 55 kilobecquerel per kilogram of body weight. The injection is given slow IV over 1 minute. IV line should be flushed before and after with saline. Now, if the patient has treatment-related cytopenia, treatment can be delayed for about 6 to 8 weeks. But if it's longer than that, then you have to consider discontinuing the treatment. There are radiation precautions because it's an alpha emitter. I mean, they're relatively less compared to other treatments we give, mainly as it's excreted by the bowel, so flushing twice after going to the toilet, washing hands, etc., and looking after spilled urine and heavily contaminated or soil garments, they need to be washed separately. Complications, most common are nausea. Some people have mild diarrhea lasting for 1 or 2 days and have a little bit really vomiting. We do tell them that they could have transient increase in pain, which is a flare phenomena. They can have mild peripheral edema, and as mentioned, they can have myelosuppression. Now, the contraindications and cautions, bone marrow suppression and spinal cord compressions are the contraindications. Also, now it's being incorporated into the guidelines. They're not recommended for use in combination of abiraterone plus prednisolone or with prednisolone because it increases risk of fractures or mortality. And patients are asked not to further a trial for 6 months. And the AMA advice now is the patient should be on bone protecting agents while they're on radiant treatment. So just a review of the patients we treated and how experience and how that compared with the trials really. So we looked at the patients we treated, looked at the overall survival, the hematological safety, percentage change in alkaline phosphatase and PSA, and the adverse effects. So it was patients who were treated from January 2016 to January 2019. It was a retrospective review, and we looked at data on electronic patient record and imaging system. Overall survival, so there were 149 patients who received radium during this time. There were about 756 cycles, averaging to about 5 per patient. We had to exclude 7 patients because there was no follow-up available on our system. So we basically looked at 142 when we're looking at survival. We calculated the survival in months from the date of first treatment. We divide them into patients who had 1 to 4 cycles of radium and those who had 5 to 6 cycles of radium. There were 38 patients in group A and in group B, 104, in which there were 46 patients alive at the time of review, which was July 21. We found that the mean survival in months was longer, about 18.9 months mean. And this, we probably think that was because of choice of patients initially. We were treating everybody, and they didn't even actually live long enough to even complete the treatment. We became more selective over time. So the hematological response, the bloods in the first cycle were compared with blood 6 to 8 weeks after the last cycle. If those were not available from day of last cycle, was used. So that's how we looked at this grading system to grade the toxicity. And grade 1 was lower limit normal to 10, grade 2, 6 to 8 grams per deciliter, grade 3 was 4.9 to 8, grade 4 life-threatening. So we found that there was no toxicity in 98 patients, and only 3 had grade 1 clear-cut toxicity. For platelets, the grading we used was 75, less than 75,000 was grade 1, 50 to 75,000, grade 2, grade 3, 25 to 50, and less than 50 was grade 4. We found that 2 of our patients had grade 3 toxicity. The vast majority had no toxicity at all. Percentage change from PSA from baseline. So as you can see, the vast majority of patients, they did end up having increased PSA during the treatment. So that's why PSA is not really a marker we use while we treat patients with radium. But we did see that about 2/3 of our patients had reduction in alkaline phosphatase levels. So the adverse events or skeletal events were about 13.6 in the radium-only cohort, and while the symptomatic skeletal events was 4%. We did not find much adverse effects in the other groups. Of the 149 patients we treated, it was well tolerated with minimal clinically significant toxicity, effective reduction in alkaline phosphatase, and minimal impact on PSA. And probability of symptomatic skeletal events was very low. We looked at briefly at another trial, ERA 223. This was a randomized, double-blind, placebo-controlled phase 3 trials. 165 oncology centers in 19 countries were involved. All patients received oral abiraterone plus oral prednisolone or 5 milligram pred daily during and after radium or placebo. So a primary endpoint was symptomatic skeletal event-free survival. 49% radium group had died or had at least one symptomatic skeletal event compared to 47% in placebo. And the medium symptomatic skeletal event-free survival was 22.3 months compared to 26 in placebo. This led to, as I mentioned earlier, the caution of not combining this radium with abiraterone treatment. So this led us to think about how many skeletal events our patients were having. So we included patients now up till September 19, and that was about 171 patients. And we looked at skeletal-related events by looking at independently reviewing their CT or MRI scans and looking at their documented clinical findings for symptoms on the electronic patient record. So we wanted to look at what was the frequency of insufficiency fracture and pathological fractures, spinal cord compression, and if they were on any bone health agents or novel anti-androgen medication. So we compared them with the radium treatment cohort reported in the ERA 223. So our results showed that we had 866 cycles given to these 177, again averaging to about 5 cycles. About 16.4 skeletal-related events were recorded compared with 29% reported in the ERA 223, so it's much lower. 64% were symptomatic, 36% were asymptomatic. We had just picked them up incidentally on imaging ourselves. So of the symptomatic, breaking them up further, symptomatic skeletal-related events comprised of mainly of spinal cord compression, 44%, and pathological fractures. The insufficiency fractures which were much less. Of the asymptomatic ones, we had about 50% pathological fractures, the patient didn't know about them, 30% spinal cord or radiological cord compression, and 20% insufficiency fractures. So we saw that only 7.6 of patients were on bone health agents compared with 39% patients in the ERA 223, which the radium treatment cohort. The novel anti-androgens were administered in only 5.3%, where 100% of those in the trial had them. We concluded with that the high fracture rate was not reproduced despite the low percent of our patients being on bone health agents in our retrospective cohort. Specifically, insufficiency fractures only occurred in 3% of our patients. And we also realized that not all imaging diagnosed skeletal-related events were clinically significant. So I'd like to thank all my previous colleagues who have treated this patient and have looked at all this patient data. Thank you. So, no question answer we do later. So I'll just announce Dr. Akif's details. So our next speaker is Dr. Akifullah Khan. He's a former president and vice president of the Pakistan Society of Nuclear Medicine. He's a renowned nuclear medicine physician of Pakistan. He's a lively professional and loves to share his knowledge and thoughts with fellow colleagues, young nuclear physicians, medical physicists, and technologists. He has more than 60, mostly international publications to his credit. He's currently working as director of one of the largest nuclear medicine and radiotherapy facility of Khyber Pakhtunkhwa province, and in IRNM, which is the Institute of Radiotherapy and Nuclear Medicine at the historical city of Peshawar.
Thank you for an elaborate introduction. Good morning, everybody. Today I'll be talking about not exactly about the management of differentiated thyroid carcinoma, but its local perspective and the challenges that we face, and how can we as a senior people in the community can guide our policymakers to make things easier for us. So I work in IRNM, which was founded some 25 years, some 50 years back in 1975. And it was the only institute for 25 years which was delivering the services in the fields of nuclear medicine and radiotherapy. Apart from IRNM, there are 5 other institutes working in different parts of the Khyber Pakhtunkhwa. So to start with my case of management of CA thyroid in the local perspective, let me show you a paper which was recently published in Thyroid 2023, where they compared 2 groups of patients. One group was subjected to immediate surgery after detecting a low-risk papillary thyroid carcinoma on the ultrasound, while the other group was kept on the follow-up. And after following both the groups for 15 years, the immediate surgery group included 1,739 patients. That were 37% of the total sample size. The sample size was 4,635 patients. They were randomized into 2 arms. One arm was only there was active surveillance of these micropapillary thyroid carcinomas, and only 242 patients were converted into a surgery group, like they underwent surgery during the course of their active surveillance. And still 2,654 patients in this Japanese study are still under active surveillance. So the developed world is facing different kinds of problems than we are facing. Then I'm now in comparison to this study, where 2,654 patients are under active surveillance in 2 hospitals, is compared to the next one case that I saw last week. And every week we see such patients in our clinics. So this 72 years old lady came to the clinic after visiting an ENT surgeon, and he did his blood tests and some of the investigations. Her TG and anti-TG were grossly raised. TFTs were suggestive of slightly hyperthyroid state, but she was clinically euthyroid. On FNA, she showed atypical cells, Bethesda 5, and she underwent an IV contrast enhanced CT scan as well before coming to a nuclear physician. So you know the anxiety of a nuclear physician before having a CT. So these are some of the tests that I could pick. But the interesting thing is her CT scan. This is her FNAC report. The CT shows the trachea and the esophagus is pushed to the other side. The tumor is extending inferiorly, retrosternally, superiorly, it is reaching up to the parotid glands, and on posteriorly, it is touching the C4 and T2 vertebra. I'll be showing you the CT scans of this patient, and you will be astonished that this woman presented to a clinic in our setup. Before that, I presented a study, Dr. Fahim, that the Japanese are following patients and what we are getting. So it's a comparison of the two worlds. And this is what we get. The left common carotid is pushed posteriorly and draping over its anterior wall and whatnot and whatnot. And this was the scan. And it's retrosternally extended. You can see upper limit with somewhere around the parotid, and it is abutting the spine. And the whole of the cervical, almost lower half, and the thoracic T2 vertebra. So this is what we get. So we did a bone scan. It was unremarkable, though there were some sclerotic lesions on the CT scan. So comparison, this is us and that is them. So we are having problems with our CA thyroid patients in our local perspective. So I wanted to share with you what are those causes where we land into such problems in our country and why we have problems with our CA thyroid patients. Their problems are overdiagnosis. Our problem is underdiagnosis. Their incidence is increasing due to better detection. Our incidence is increasing due to higher population. They are exploring genetics for early detection and surveillance. We are still finding a good FNA report in the city. They are concerned about over-treatment with surgeries and radioactive iodine therapy. Yes, we are also sometimes very much concerned about over-treatments in our patients, but under-treatments are more of a problem in our scenario. So we, the nuclear physician, we want that the patient should come up in the early stage of the disease. Rather, any doctor would like that the patient should come in the early part of the disease. So I'll be discussing each of these small bits in a bit of a detail, like inadequate awareness, no screening program, disparity in the healthcare system, compromised specialized care, financial constraints, socio-cultural taboos and beliefs, and lack of a centralized cancer registries. Interests in a specified goal-oriented research, dietary factors, and geographical and logistic issues. So inadequate awareness. We consider always the endemic goiter to be a benign and innocent thing. And most of in our villages, especially in the hilly areas, they think that an MNG is there and it's a normal thing. Their grandfather and their grandmothers had an MNG and they lived for 90 years, so nothing to worry about. And occurrence of a malignancy in a multinodular goiter is considered to be out of question. But the fact is, an MNG is as prone to develop a malignancy and this old dogma should be kept aside. A GP always believes in forgetting your MNG. Let's do other things, and he will tell you to come up for a follow-up, and the patient is lost in the follow-up, and he comes up with a disease, which is then, as you saw in the earlier slides. So we don't have any screening program, unfortunately, very unfortunately, and we have been advocating this screening program for breast cancer in the last October month, and in every forum I raise this issue of screening in the breast cancer. Advocacy is very important. So we need more advocacy in the thyroid as well to develop some screening program. An anxious and educated patient may come up with a small nodule to you, but it's very rare in our setup. We get a micro papillary carcinoma or a less than a centimeter papillary carcinoma only as an incidental finding in an operated MNG, because MNG is operated for a big mass, and then you in between that you get a small focus of papillary CA. So we have got a very different strata of healthcare in our country. Some facilities are very well equipped, and mostly they are not that well equipped. Ultrasound is the most useful imaging tool in understanding the pathologies of the thyroid. But unfortunately, we don't have a uniform reporting system for reporting on a thyroid ultrasound. We don't see too much of a specialized equipments and expertise in our setup, and most of the people report just an MNG or multinodular goiter at the end of the reports, and they don't categorize each nodule differently. So we would like that people should be trained to understand that this doing an ultrasound is not to detect some gola in the thyroid. Gola are palpable to the physician, and he can do it without your assistance, and he can approximately measure it as well. It is how much centimeter with his thumb. But what you are supposed to do to tell the physician that whether it is malignant or whether it is not, and so to characterize it. And then fine needle aspiration. In the early days when we used to do fine needles, and whenever we could find a follicular cells on the report, that we have done a good job, like we have put the needle in the thyroid. And then later on we came to know that putting the needle in the thyroid is not that important. Putting the needle at the right place in the thyroid is very important, and that can be identified by a good sonologist. So fine needle aspiration is usually done from the non-representative sites, and you get a lot of false negative reports on the FNAs because of your not picking up the right specimens from the thyroid. And then the dilemma for follicular carcinoma. We have a lot of follicular carcinoma in our scenario because it's an iodine deficient terrain. We are draining at Irnam and at Swat. So these follicular carcinomas on the FNA, they are resembling the normal follicular cells, and the tumor cells are not very different from the normal follicular cells. So on the FNA, you cannot differentiate in them. Then comes to the preparation of slides, specimens, fine needle aspiration. Reports are not that, and we are still going through a learning curve in fine needle aspiration. So we have few good reporting areas where you can get a good sonology and good ultrasound, but they are now so overworked because now they have lost their quality as well. So even at Shaukat Khanum, we send a lot of patients, but they are receiving so tremendous number of patients that we can understand. I think it's automatically forwarding. Okay, so I think you're not fiddling with the things. Okay, okay. So we have a disparity in our FNAs as well. Then come to surgery. Surgery is a place where we need a lot of work now, and some specialized oncological facilities like Shaukat Khanum has the facility of having a specialized surgeon, but most of the time we don't have, as you know, many tumor boards available. So anybody who can get hold of a patient and he operates that patient, and sometimes he may be a general surgeon, he may be an ENT surgeon, he may be a head and neck surgeon. So we don't have high volume specialized surgeons available. So the patient comes with a too little surgery mostly, and sometimes too much surgery. I have seen patients being operated for a T1 lesion with a total thyroidectomy and hypoparathyroid. Saad, you will agree to me, with recurrent laryngeal injuries. So too much of a surgeries are also a concern when you don't discuss with your fellow colleagues that what are the latest things coming up. Now, you don't do total thyroidectomies in T1 lesions. So this is what need to be addressed as well. So we have limited facilities of the isolation rooms, poor preparation in radioactive iodine therapy patients, injudicious use of iodine, and we are not keeping an eye on the long-term consequences. A person who has been treating CA thyroids for the last 27 years, like me, can have now the consequences of his patients after 30 years or after 25 years, rather than a person just entering into the nuclear medicine practice, and he may not be seeing any of the complications. It's a very safe thing. So those things should be kept in mind when to give and when not to give. The not to give decision is also a very important decision. We put a patient on thyroxine suppression and some GP would stop it or say, oh, you are toxic. Why is giving you a thyroxine? And the thyroxine is stopped by the GP and the patient comes swollen with a recurrence. So calcium and vitamin D intake, and that is also a problem most of the patients have when they have a hypoparathyroidism as well. Pediatric CA thyroid is a very big concern in our region, and especially when they have advanced disease and when lung mets. So we need to sit for that, and we have a lot of patients. So financial constraints are everywhere, but here in Pakistan, they are, and especially in the region we are working, FATA and KP, they are the poorest of the country. They have problems in their logistics, their transportation, especially if the cost of the accompanying person. Then a radioactive patient has to be transported in a separate vehicle, and that radiation related things can be minimized by hospitals should be providing them the escort or the transport for the traveling back home when the patient is radioactive. Now, some interesting things. Socio-cultural taboos. Still, people believe in the tying a cotton reed around the neck will heal the goiter. And this is when I just searched Taweez for goiter. So this came up, Taweez for cancer. So you can see I have hidden the name of the Mufti Saab. You might not refer him patients. So and you see these tattoos on the face of this lady. So these tattoos, or these we call shinkhal. So the shinkhal are also they're painted on or they are done on the goiters to reduce the goiter. Somebody told me that it contains iodine, so it may reduce the goiter somehow. So these are things patient does not have a say in the house and in the family. It has to follow the mother-in-law sort of a philosophy. Mother-in-law says, okay, take him to the Dam and Taweez, and so the patient has to be treated like that. And or sometimes I have seen patients who had burnt their skins over the necks. There is a Peer in Mardan who does this practice. वो उसको लोहा गर्म करके वो उस पे रख देता है skin पे. So this also happens in this part of the world. We don't have any centralized cancer registry. So Atomic Energy has done some effort putting up 20 centers data in a book form, and IRNM is planning to publish its 25 years data in the next year when it will be our golden jubilee. So hope to have more data. So our research is also very scattered, and we don't have any purpose-built research. A lot of universities, we have medical universities, we have a lot of other universities in basic sciences, but what they are doing is giving away people's certificates for MPhil and PhDs. Their research is not contributing neither clinically, nor to the development of the industry. So we need to focus our intentions. And this is one cartoon made by a young boy from India, and they're so aware, like iodine deficiency is such a big issue over there as well. But we don't have any awareness activities in our schools, in our colleges about iodine deficiency and goiters. And mostly patients live in our part of the world, far-flung areas. They have to travel all the way from different terrains. So their logistic issues should be. So the way forward is we need to start advocacy for screening in the thyroid, uniform training on imaging and reporting a thyroid sonogram, guidance on what to aspirate for cytology, and the image-guided FNA with a pictorial that I have taken the specimen from this particular gola, not from non-representative areas, and uniform Bethesda classification. Mostly we get a report of a cytology, no malignant cell seen. So what about the other cells? and identifying expertise in better surgeries, thus reducing the complications by old. This week, I had a patient in my isolation rooms, and she had all her parathyroids removed. She was 17 years of age, and she had repeated episodes of hypocalcemia, and she had to be infused. Even she was given radioactive iodine, and we had to arrange her radioactive iodine in emergency because we wanted her to replace her on thyroxine, because with the thyroxine, some of the symptoms may improve. And we need better facilities for the adjuvant treatments, genetic testing in the high risk groups. And I'll be available for the question answer session. At the end of the session, I'll be moderating as well your question answer session. And this is our last addition to Atomic Energy Cancer Hospitals. And this is built in Gilgit, we called Ginor, Gilgit, Baltistan. Thank you all of you for your patient listening.
Thank you very much for such an excellent presentation. I'd like to ask Dr. Fahimul Hasan to come again and speak about the SPECT-CT imaging at its best. Thank you.
So Hajra and Akif, thank you. Okay. So thank you again for asking me to present something on SPECT-CT. So the aim of the talk is basically, if you are not already convinced that SPECT-CT should be your part of any modernized nuclear medicine department, my aim is to convince it to you. And after this talk, if you're still not convinced, only Allah subhanahu wa ta'ala can help you. Okay. So Guy's and St. Thomas's was the first trust in the country, in United Kingdom, to have SPECT-CT. So we had a long experience. I started training as a registrar in 2008. And I'm not gonna give you lots of, because I personally actually don't like the talks where there's a lot of data. Like Dr. Akif has presented the real-time problems and then the solution. So I will just show you basically some of these scans or what we do at GSCT. It's always tell you to basically share your own experience, and then the audience can tell how faulty you are actually. Yeah? So what we do at GSCT may not be right, but that's what we do. So all patients with prosthetic joints, with prosthetic joints actually gets a two-phase SPECT bone scan and a SPECT-CT. All peripheral joints, which we use SPECT-CT as a problem-solving tool. So they have ultrasound, they had MRs, but still the orthopedic surgeon, the hand surgeon, the knee surgeons, the hip surgeons are looking for something because the patients still have got pain. Okay, pain generators in spine. Patient had MR spine. There are multiple fascial joints. There is neural impingement. Which one is the active thing? Just like Dr. Akif has said that when you're putting it in thyroid, where is it actually where the pain is getting generated? It's a brilliant test, believe me, for SPECT-CT. Post-operative spine, very good modality for SPECT-CTs. And we also use SPECT-CTs for one-stop shop for oncology bone scans. So patient has come us with a prostate cancer. They didn't have a CT scan very recently. Okay, you see a spot in their lumbar spine. You think it's probably degenerative. Okay, write a report to probably degenerative. What does that mean? That means that the patient goes back to oncologist in 2 weeks or a week, and the oncologist just hates you because you have written probably degenerative, needs exclusion of malaria. So that means another CT is now booked. Okay, that takes another 1 or 2 weeks. So the whole journey of that is extended to weeks and weeks. Whereas what you have done is you have just imaged a very small part of the spine just to localize this, seen on CT, it's degenerative, given a report that there is no metastatic, osteoblastic metastatic disease, okay? We do lots of therapies. We are the first or the second largest trust for the thyroid cancer. And like in this country, all thyroid cancers, especially in guys, are followed up by nuclear medicine team. Okay, so we do all the post-therapy scans are with SPECT-CT. So that includes iodine, PSMAs, peptide receptor therapy. So Guy's is also a national referral center For neuroendocrine tumors, we re-challenge them. We also treat lots of paragangliomas, olfactory neuroblastomas, etc., unlicensed indications of PRRT, and similarly, occasionally with MIBG. Diagnostic scans with iodine 123 MIBG and 123 iodine diagnostic scans all get SPECT CTs, and all our VQ scans, except for pregnancy where we only do VQ SPECT, all of our VQ scans also get SPECT CTs. And then localization for parathyroid adenomas, miscellaneous like cardiac amyloidosis, occasionally we do SPECT CT. And also for infections, after doing bone scans, if we still think that we can't rule an infection, for a white cell scan, we do it for localization and better characterization. So I will just, we are lucky basically because guys also got a big MSK center, musculoskeletal center. So all of our musculoskeletal SPECT CTs are double read. So we do the initial report and then the MSK comes and adds its bits. So simple things are that basically, and a simple approach to MSK is you look at the clinical details like you do it in every other case when you report. You look at the previous scans. It depends on you, basically, how do you want to start it? Some people will start from whole body to explain, then two-phase, and then SPECT CT. So you describe the bones, the joints, you describe what kind of tracer uptake, it is multifocal, diffuse, or it's only focal. And obviously, even if like people like me who are only nuclear medicine physicians, I've seen enough of these. So you start learning about to describe muscle bulk, and sometimes you have to be really patient because you have to then also ligaments and tendons, which generally the MSK will, especially in ankles, in hands, which I have no clue. So I'm just going to show you some cases. Okay, so this is a patient who was referred for a painful right THR. The question is, general one is loosening or infection. And so you can see, sorry, the point there. So a photopenia on the early blood pool image. So that is your THR. And here you have got a planar delayed image, and you can see that there's a articular increased activity along the acetabular replacement, and there are two lines going towards the hemipelvis. So you did a SPECT CT, and you find out that there is a lucency and also lucency along the two screws. So the diagnosis is loosening of the right THR. Okay, but if I show you a CT of the same patient, what do you think? This should be actually an interactive session. I don't know whether I can do the interactive session or not. So this is a CT component of a same patient. Okay, I will give you another go if possible, and then I will explain you what happens. Okay, so you can see that there is expansion of the right iliacus muscle. So if I can, I know basically it's a bit difficult to scroll through this. I will stop here and I will try to scroll myself. So you can see a low attenuation area, okay, and then a high attenuation area. So this patient had actually a large hematoma, which was on this right pelvic wall. So without CT component, we would have never picked this up. Okay, painful hips, right THR, similar question. So you see the early blood pool images, there's no vascularity. The right THR doesn't show much actually, and there is some focal uptake in superior aspects, but probably that is degenerative. But what else you can see? So you see that there's a low-grade increased activity in the left femoral, proximal femoral component. Yeah. Okay. We did a CT and that SPECT CT, and that also shows that the whole of your left side is actually shows diffuse low-grade osteoblastic activity. And then the same patient, you have got these findings. So I'm not that clever, but there are clever radiologists sitting here. What do you think is happening here? Okay. And if I show you the whole body bone scan, what do you think is this patient having? Okay. So there is I'm not going to question your judgment. You can answer anything. But look at the left side. So this patient had a left femoral head AVN. There is sclerosis of the sacrum, and this is bone infarct. So this patient had sickle cell anemia. So without CT, we wouldn't have actually, so the patient was almost asymptomatic. So loss of volume of the left femoral head with femoral neck, trochanteric and diffuse sacral sclerosis, and also a bone infarct in the left humerus. Okay, next one. So this patient, again, bilateral THR, pain, same question. Nothing much on the activity-wise. If you see, I intensified the image just to show that there is no uptake. But look at the CT. So the CT shows that there's marked rarefaction and periprosthetic cyst formation at the acetabula. And in this case, this is still loosening of the bilateral components, but without any significant osteoblastic activity. And this probably reflects the reduced quality of your bone stock. So that's why it's not triggering the osteoblastic reaction. And what other diagnosis incidental we made on this bone scan? Come on, guys. You all have seen this. So this patient had cardiac amyloidosis as well. So that was an incidental finding. Okay, next one, right THR, similar. So questions remain the same. The orthopedics only ask about EU, whether this is an infection or this is loosening. What do you see here? You see that there's a focal uptake in the right trochanter. Doesn't look like loosening, isn't it? No increase in vascularity. So this was no, and I haven't shown you the CT, but there was no cortical break. So this wasn't a fracture. So this turned out to be a stress phenomenon related to the traction at the iliopsoas insertion. Yeah. So we move to the, although you have said, asked me to cover spec CT in 20 minutes, if you would have only asked me to cover hips and knees, I would have taken an hour almost. Yeah. So there are so many cases, but I'm just going to use some general examples. So you've seen a pain left TKR 5 years ago. So there is increased vascularity in synovial distribution. Yes, there's low-grade activity involving the left hip, but left knee replacement. But the patient at the time of questioning, when you image, they said, I've got more pain in the right knee joint as well. Okay. So you probably look at this and you think, oh, there is probably some degeneration in the medial compartment and probably somewhere in the mid of the right knee. We did a SPECT CT. So the SPECT CT shows basically some lucency around the tibial component. But look at the right side. And I will show you the right side. So this is right knee. So the right knee actually shows that there is basically spiking of the tibial spine. There's intercondylar uptake. And then there is anterior translation of the tibial plateau related to the femoral condyles. This is a feature of ACL deficiency. So this patient had actually anterior cruciate ligament deficiency in the right knee, for which was confirmed on the MR. So painful, another patient with painful right TKR. So this time there's a focal uptake in the proximal lateral shaft of the tibia. Okay, what is this then? What do you think this is? Spot diagnosis? Okay, I'll show you this. Only focal uptake. The rest of the prosthesis looks fine. Cortical break. So this was actually a stress fracture of the right, of the upper lateral to the right tibial shaft as a result of underlying exuberant cement filling. Okay, left TKR infective. Yes, probably there's increased vascularity. There's a lot of tracer uptake on the delayed images. There's lots of sclerosis. Yes, infection. I just wanted to show you the CT of this patient. Look at the left knee. So what is this? Hajra knows all of it, but she's very nice to me and she's not telling the answers, you know. Okay, I will show you CT again one more time. And then, so obviously we have got the evidence of periprosthetic osteomyelitis, but there is a large abscess here. You have seen, must have seen gas locules, and there was a cutaneous fistula as well. Yeah. Okay. Another patient with painful left TKR, previous left THR, infection, inflammation, increased vascularity. And this is the CT component. And I will be quick now because I will be otherwise running out of the time. This is active heterotrophic ossification in the distal femoral diaphysis. Okay, you wouldn't have actually picked this up only on here. There was some loosening, but because there was so much increased vascularity, we ended up doing white cell scan. So there was congruent tracer uptake between the white cell indium and the marrow study. So this wasn't infection. This was actually active heterotrophic ossification with loosening of the tibial component. And next comes quickly of the spine. So this patient had, so spot diagnosis, please. So this patient had severe scoliosis. We knew about the degenerative disease, but there was something in the upper spine, lumbar spine. She was just saying, I've got pain here, pain here. So other than the degenerative disease. So this turns out to be a fracture of Harington rod at L1, L2 vertebra. Yeah. Next one is lower back pain, another patient, nothing. Sorry. Next patient is basically, again, I think this was a generalized pain. I wanted to show you basically, this is very important case, only case which I've ever seen like this. So there was a back pain and this gentleman is only 40. So it doesn't show much uptake. And look at the spine. So spot diagnosis. So spot diagnosis is multiple lytic lesions with multi-level vertebral fractures. This patient had multiple myeloma. So that's the case basically that you don't do bone scans in multiple myeloma. You do either a whole body MR or an FDG PET because lytic lesions don't show you much osteoblastic reaction, okay? So this patient had a procedure on the left shoulder. So coming to left shoulder now because I have to cover all these PEC CTs, okay? A procedure and then continuous pain after a year after the procedure. So what can you see on spot? This can't be a spot diagnosis, but you can see that there's some asymmetrical uptake in the left shoulder. SPECT CT shows that there is pseudo-orthosis. So this patient had post-letter jet. So in letter jet, basically what you do is you put a bone graft to the anterior glenoid cortex to prevent the instability of the left shoulder. So this patient has non-union. You can see the non-union between the bone graft and anterior glenoid cortex. So pain was coming from there, okay? And next I move to the wrists quickly. And I will have to be quick now. So the patient had pain in the left side and query cause. So what do you see here? What do you see in this bit? Okay, so this is basically look at between the scaphoid and lunate. Okay, so the normal distance between scaphoid and lunate is around 2 millimeter. Here it's 8 millimeter. So this is marked scapholunate dysfunction with gross widening, and there's proximal migration of the capitate. Yeah, it's coming towards you. It shouldn't be here. Okay, next one is another patient with pain on the ulnar aspect of the right side of the right wrist, and there's an uptake in the ulnar proxcarpal row, and this patient had gross TFCC ligament dysfunction, which was also proven later on MR and ulnar abutment. Another patient I would actually, because this will take a long time to explain, so I may skip. So, but these are Madelung deformities. I will just show you the next one. So this patient had multiple joint pains, and this condition usually occurs in Pakistan. So you guys have to guess this one, okay? So multiple joint pains, okay? So this was the bone scan on this patient. So we ended up doing SPECT CTs. So SPECT CTs, I will just show you quickly SPECT CTs. So where I work in Guy's and St. Thomas's, there are 120 languages are spoken. So it's a very diverse place where in central London, okay? And I will show you again, okay, I will show you quick CT images on this patient. Okay, have a guess now. What do you think? What do you see in feet and what do you see here? Okay, I will just point out towards here as well. What do you see in this image here and what do you see here? Come on, guys. This happens more in Pakistan than in London. Okay. So it's a widespread sites of metabolically active enthesopathy. You can see calcified ossifications. Yeah. So this is consistent with heterotrophic mineralization of rickets. There is interosseous bone formation between the right third and fourth metatarsals in both feet. Yeah. So you diagnose rickets from a SPECT CT. Not that I would suggest that. So patient with bilateral calcaneal pain in a systemic illness. Okay, you see increased vascularity in the calcaneum, bilateral calcaneums, yeah. You see CT, there is a slight sclerosis, increased uptake. This patient had sarcoidosis with bilateral infiltration in the calcaneum, SPECT CT. Patient with a previous trauma, hind foot pain, increased activity in your talus. So I will have to go through quickly now. So this was left foot pain, AVN of talus joint, yeah. Pain right foot. Please give us the pain generators. You see a focal uptake in the medial malleolus. You also see on the lateral images that there's focal uptake in hind foot. What it can be. I have to be quick now. Os trigonum, os navicular. Both active, both giving pains. Yeah. So this was a posterior impingement and also active os navicular. So moving on to quickly a carcinoma of breast with previous bones and liver mets. Spot diagnosis. Spot diagnosis. Spot diagnosis. Okay, yeah, thinking of Paget, but this is mandible. Previous bone and liver mets? Yes, osteonecrosis of the jaw. Thank you. Next one is a young patient who's having a lower left leg pain. SPECT CT. Diagnosis. This is the only one I've seen in my life, so I wouldn't actually expect diagnosis. But there's permeation, there's marrow infiltration, lymphoma. Okay, on a bone scan. So we asked basically that this looks like lymphoma, proven to be lymphoma. Okay, VQ SPECT CTs. So the patient history, palpitations, chest pain, raised D dimers, question mark, pulmonary embolism. Top ones are ventilation, bottom ones are perfusion. I wouldn't ask you to diagnose on this, but I would ask you. So these are all real life cases, okay, happening in emergency. So this was reported by one of our residents. And this is the SPECT CT. So have a look and you have to tell me what is happening here. Sorry, the CT quality doesn't come, but this is real life CT, okay? So real life questions, basically you have to answer. Okay, palpitations, chest pain, raised D dimers. So we said basically that the patient doesn't have PE. Patient went to a cardiologist, so we couldn't diagnose what was in there, okay? Patient went to a cardiologist, had an MR heart. The person who reported MR heart also missed the diagnosis. 3 months down the line, she came as admitted as hypotensive crisis. Diagnosis, scan and diagnosis. Okay, look at the images again. Now you must give me the diagnosis. Guys, it's hypertensive crisis, it's palpitations, pheochromocytoma. So very good. Okay, let me show you this. So missed by 2 people, 2 radiologists. So look at this, right sitting there. Yeah, big mass. So it's important, whatever you are doing, you look at everything. Okay, look at everything, please. Next patient, another VQ scan, similar story, spot diagnosis. So we normally use Krypton, but on this day DTP was available, so that you can see the aerosols basically because of DTPA. This is perfusion. What actually comes out on this? Sorry, go on. I mean, this is no judgment, so you can guess it because these things were missed by us. So I'm confessing here. You know, our department missed these things. That's how we learn. Okay. SPECT CT, I'm just going to show you again. What can you see? Sorry, if I have gone, yeah, this is the right one. What can you see? Sorry? Massive? Massive heart, excellent. So I go back actually, very good. Can you see cardiomegaly? Yeah. So you can see SPECT only on SPECT that this patient has got why should a 24 years old person should have this kind of cardiomegaly? Suddenly a kind of thing, yeah? Okay. Large, massive pericardial effusion causing cardiac tamponade. So VQ SPECT CT. Painful left ear, known otitis externa. Is the infection gone? Bone scan? No, it doesn't look like. SPECT CT? No, the infection hasn't gone. So there is still an infection involving the left zygomatic process of temporal bone viscosis and left side of sphenoid, greater wing, and sphenoid sinus. You don't need a white cell scan. The MR also confirmed these findings. I'm coming towards the end now. So Dr. Akif, your patient and mine, patient with the follicular thyroid cancer, we knew about this. Bone metastasis, we knew about the thyroid disease, but I didn't knew about this. Okay, so this is the only case of my kind. Basically, for last 15 years, I've treated hundreds or probably thousands of patients with thyroid cancer now. This was a destructive lesion in calcaneum, biopsy-proven follicular thyroid cancer. So the only site of solitary metastasis in the whole body was only in calcaneum. Okay, SPECT CT again. I'm coming towards the end. So this patient was referred because on abdominal pain, CT says that there is a pancreatic lesion, likely neuroendocrine tumor. A gallium dotatate scan was performed, possible neuroendocrine tumor in tail of pancreas. An MR was performed, indeterminate. Can this be intrapancreatic splanchus? So what is this scan then? Very good. Yes, screen scan. Okay. So you see an uptake or activity. Yeah. So this was intrapancreatic splanchus. So SPECT CT, you would see every single thing you can use SPECT CT. No? It's not only for bone scans anymore. Okay. Coming towards the end. So this is cardiac amyloidosis. SPECT CT. I'm not going to go into Pergini score. How do you rate it? But generally, we use SPECT CTs in not in grade 3, which is this is grade 3. This was used because there was activity within the ribs, and we were not sure what is happening in the thorax. There wasn't much. So we normally use usually in grade 1 or grade 0, just to make sure that we are not saying that this is false negative on bone scan. Yeah. One of my favorites here. This one is one of my favorites, actually. What do you think which is this scan? It is gastric, but not emptying. Yeah. Very good. And what do you see here? Normal scan? I mean, I've never seen how many people see Meckel's diverticulum? Hardly. You must be seen here in England. It's always eyes closed, normal scan. But what we saw here is this thing. And we thought what it is. Okay, because we have got a SPECT CT, let's do a SPECT CT. Yeah. And I will just show you more clearly. This was a large Meckel's diverticulum. Okay. So I will finish by this. Thank you so much. I hope you have enjoyed the images. Thanks.
We have got one virtual talk, and Dr. Hajar will introduce the speaker.
So we have Dr. Christina Nani with us. She's a nuclear medicine physician and radiologist with more than 20 years of experience. She specializes in nuclear medicine with a focus on clinical application of PET-CT with FDG and novel traces in various fields of oncology. She has always also been performing multi-phase total body CT associated to FDG PET for oncological purposes since 2010. And her area of expertise is FDG and novel traces on oncology, myeloma, prostate cancer, infectious inflammatory diseases. We are very lucky to have her speaking to us today. She was online earlier, wasn't she?
Here we will take the panel discussion right now, because we have some time if she becomes online. So we have got 4 talks available with us if somebody wants to discuss or ask some questions related to that. Yes, ma'am. Can somebody? Mic there.
Assalamu alaikum ji, and I am a Shaukat Khanum alumni. This is working. Now it's working.
Yeah.
Currently, I am working as an assistant professor of radiology at Emory University. So excellent talks by all the 3 speakers. My question for Dr. Fahim, excellent overview of LEU-PSMA and the trials, the 2 landmark trials that we had, vision and therapy. I think most of us who are administering LEU-PSMA therapy, the main question or dilemma that we are facing these days is lack of predictive biomarkers. 2 patients, exactly the same demographics, the same patient characteristics, how one patient responds and the other doesn't. And as you very much outlined, the post-therapy SPECT-CT images at least provide some insight, whether to proceed and continue with the therapy. They do provide some prognostic information. So what has been your experience?
Yeah, I think this is an excellent question. I haven't touched actually about that with SPECT CTs. You can also do dosimetries and actually the tumor absorbed doses. That is a different scenario and a different kettle of fish altogether, So we haven't started yet doing SPECT, but we are actually in this progress. The problem in London especially is that we get patients from all across the country. And as you know, for dosimetry, you have to do serial imaging. So our physicist always says 5 or 7 endpoints. So without 5 or 7, and that means basically staying in London for 5 and 7 days. Like Dr. Akif has said, we have got our own issues. Every country has got our own issues. So either I think we have to come to this stage that our physics and our scientific committee, basically the scientist has to come with the easy issues with dosimetries. So whether they do either blood dosimetries or whether the whole body, so that it's generalized, simplified, and it can work nationally. At this time, the problem even in England is that all the cameras have the same settings, even in London, So if someone is doing dosimetries in one place, your results may be different from a hospital across the other street. So one thing is that. The other thing which we have talked about, the tumor biomarkers, I think this especially, I showed you a patient whose PSA was 3.4, okay? Yeah, and on every single known thing on planet, he was tried that. So he went through all these trials. He went through Abitron, enzalutamide, cabazitaxel, every single thing, radium, and then to PSMA. So the only way we found out that unfortunately was post-therapy scans. You must think of post-therapy scans as in every patient, okay? That is a no-go because this is cheap. The other things which I do is where I'm, because so the treatment, basically the trials also shows that people who have completed 4 cycles, they will get the benefit at least. So there's no point of starting someone where you don't think that you can complete the 4 cycles or 6 cycles is the best. So I would do is 4 weeks post 4th cycle, we'll do a gallium PSMA, okay? Now, that's another discussion for another time, that how do you report PSMAs scans, because whether you report them as per the ENM guidelines of PPP, or you just say visually. That's another discussion. But I think that will really helpful, because if you are found out after 4 cycles that there are 3 or 4 lesions, I think you should stop. If you have shown out that there's a partial or a complete response, you should complete with the 2 cycles. Yeah, thank you.
We have some questions from those participants who are attending us virtually. And there's one question from Tanzil Sajid, and she wants to ask Dr. Fahim that is there any role of extended lutetium therapy in metastatic cases who are having some response or partial response to, so will dose escalation or extended therapies?
So the mic is still working, yeah? Excellent question, okay? Yes, there is and there is not. In Germany, they have actually re-challenged people, okay? So just like think about if you are treating patients with PRRT with lutetium dotatate. It's a common thing now, especially in center in whole United Kingdom, is because of the expenses and logistics, we only give 2 more cycles of lutetium dotatate. I think you can treat. So for example, a patient with metastatic castration-resistant prostate cancer has shown excellent response. Your PSA has almost becomes undetectable or near undetectable. But then you have to see how long it has taken after stopping of this 6 cycles that your disease has reoccurred, okay? So or relapse. So basically, if your disease has relapsed within 4 weeks, you're not going to give them another 4 cycles. So no one exactly at this time knows when to retreat them. So if someone has shown like say 6 months or 12 months, should we give another 2 cycles? So hypothetically you can, but there is no prospective studies. So the person who has asked is, I think, Tanzil Sajid. So Tanzil, you should read the ENM guidelines of 2023. In conclusion, they have actually addressed this issue, but they have said that we can neither tell you or not tell you, but there's no evidence that we can actually at this stage give more cycles. Thank you.
Thank you. We will have more questions after the last talk that is virtual by Christina Nani. She has already been introduced by Dr. Hajra. So welcome, Dr. Christina Nani. Can you hear us? इनका
Hello,
yeah,
can you hear me?
yeah, you are audible now. Thank you. Yes, we can
Good
hear
morning.
you. Good morning. You can share your screen, please.
Sorry, I sent you the pre-recorded presentation.
Okay, okay. We are playing that pre-recorded presentation for you.
Okay. Thank you very much.
You'll be available for the question answer after the end of the
Of
session.
course.
Thank you. Thank you.
And this is the outline. First paragraph will. Good morning, dear colleagues, and thank you very much for inviting me at this very nice meeting, actually. It's quite a pity not to be with you in person, but this is my contribution anyway. The title of the presentation is Update on PET-CT in Multiple Myeloma. And this is the outline. First paragraph will be on new concepts on FDG, especially regarding genomic and MRD, new traces and theranostic. But let's start from a common knowledge and a milestone of PET-CT in multiple myeloma. And the concept is that this procedure is actually the best imaging procedure for therapy assessment. And this is related to its very strong prognosticity before therapy, but even more after therapy and in the pre-maintenance phase. And this is within the guidelines that International Myeloma Working Group has suggested since 2017. And as you can see here, FDG is a very strong prognostic factor, being related to progression-free and overall survival. And this correlation is strong if we have a complete reduction of FDG uptake in all the lesions, but even more prognostic if we have a positivity cutoffs after therapy, which is the score 3, both for the bone marrow and focal lesions. So FDG PET is really, really impressive in terms of the capacity to stratify patients after therapy. But let's move to the first topic about the relationship of genomic mutations and FDG PET, why PET is so prognostic. Let's briefly see what exactly genomic is. Genomic is an interdisciplinary field of biology, actually focusing on the structure, function, evolution, mapping, and editing of genomes. A genome is an organism's complete set of DNA, including all of its genes as well as its hierarchical, three-dimensional structural configuration. In contrast to genetic, which refers to the study of individual genes and their role in inheritance, genomic aims at the collective characterization and quantification of all of an organism's genes, their interrelation and influence on the organism. Genes may direct the production of proteins with the assistance of enzymes and messenger molecules, and in turn, proteins make up body structures such as organs and tissues, as well as control chemical reactions and carrying signals between cells. Genomics also involves the sequencing and analysis of genomes through the use of high throughput DNA sequencing and bioinformatics to assemble and analyze the function and structure of the entire genomes. Advances in genomics have triggered a revolution in discovery-based research and systems biology to facilitate understanding or even the most complex biological systems such as the brain. Next generation genomic technologies allow clinicians and biomedical researchers to drastically increase the amount of genomic data collected on large study populations. When combined with the new informatics approaches that integrate many kinds of data with the genomic data in disease research, this allows researchers to better understand the genetic basis of drug response and disease. In recent years, genomic studies have been applied in multiple myeloma as a model to better understand the relation between genomic expression and multiple myeloma patterns, and therefore to predict the temporal clonal evolution in the disease, beside spatial clonal heterogeneity. Myeloma is not a single disease, but is rather comprised of a number of molecular subgroups characterized by specific chromosomal aberrations. Acquired genomic events associated with the progression lead to further interhand interpatient clonal heterogeneity, translating into different clinical outcomes. Multiple myeloma is a particularly interesting model system to gain insight into the molecular progression in cancer because its mutational load falls in the middle of the range of mutations, since in cancer lying somewhere between a genetically complex solid malignancy constrained in its evolution by neighboring cells, and the genetically simple leukemia, which is distributed throughout the bone marrow with less anatomical constraints. Due to its sensitivity, ability to detect disease in a pre-morphological phase, and prognosticity, FDG-PET-CT has been in fact very useful to identify different disease patterns that have been evaluated genomically. It is very well known that active myeloma may present with a negative FDG-PET-CT or with hot diffuse bone marrow with no morphological changes, hot or cold lytic lesions, hot pre-morphological focal lesions, paramedullary and extramedullary lesions. Different patterns imply different prognostic stratification, being better treated for those patients with a negative FDG-PET at staging. Since in multiple myeloma malignant plasma cells expand within the bone marrow, a rapid dissemination of fetal clones may be anticipated with FDG-PET-CT that can be used to drive the biopsy to different pre-morphological areas of plasma cells accumulation to provide a genomic characterization of as many lesions as possible. In this study, for example, multi-region sequencing, including iliac crest and imaging-guided focal lesion specimens from 51 patients, have been performed with the aim to gain insight into the spatial clonal architecture of active multiple myeloma. It has been demonstrated that there is spatial genomic heterogeneity in more than 75% of patients, and that the extent of spatial heterogeneity is positively associated with the size of biopsy focal lesions, consistent with the regional outgrowth of advanced clones. The results support a model of multiple myeloma progression with clonal sweeps in the early phase and regional evolution in advanced disease. Interestingly, the spatial heterogeneity turned out to be associated with the size of focal lesions and impacts on outcome. Bigger focal lesions demonstrated a significantly higher number of unshared mutation and put the patient in a worse prognostic curve. In this representation, red squares indicate the presence of unshared mutations that genetically correspond to a higher number of unshared copy number aberration between paired iliac crest and fine needle aspirates. According to the result of this paper, therefore, the model of spatial heterogeneity where ancestor clones in green containing initiating aberration occupy the available plasma cell survival niche in the bone marrow and lead to monoclonal gammopathy of undetermined significance. In the first phase, additional mutation result in subclones with increased thickness and multiple selected sweeps of advanced clones in yellow finally replaced engulfed projectors. In the second phase, all available needs are applied by advanced clones, increasing the environmental constraints. At this stage, the likelihood of invasion and sweeps is decreased, favoring regional outgrowth of highly advanced clones. The genomic heterogeneity is not only spatial, but also temporal. The genomic analysis of lesions after treatment demonstrated that three different evolutionary patterns reflected by PET are present. These include the expansion and sweep driven by single tumor cells, coexisting expanding subclones, and site-unique expansions of distinct subclones, with the main difference between the second and the third pattern being the anatomical location of subclones. Box plot demonstrate the association between these patterns and the number of PET-positive focal lesions at baseline and the response to first-line therapy. It is clear that patients with pattern 2 after therapy with the coexisting subclones are those with a higher rate of non-complete response to therapy and confirm the prognostic role of PET-FDG. Here, the evolutionary
Hello? I cannot hear anymore.
myeloma include the analysis of free DNA in the bone marrow, so called DNA, and the circulating cell-free DNA in the peripheral blood. The cell-free DNA or cfDNA refers to all non-encapsulated DNA in the bloodstream. cfDNA are nucleic acid fragments that enter the bloodstream during apoptosis or necrosis. And normally these fragments are filled up by macrophages, but it is believed that the overproduction of cells in cancer leaves more of cfDNA behind. A portion of that cell-free DNA originates from a clone. The cfDNA has been genetic and alteration of cancer, including mutation, copyright alteration, chromosomal rearrangements, hydrogenation, or activation. On the other hand, ctDNA in the bone marrow affects this plasma cell concentration. And therefore, by measuring the amount and the quality of ctDNA and cfDNA responsible material, you have a complete genomic evaluation of the disease. Differences between the two may in fact be associated to a more heterogeneous disease and a worse. Clearly, there are still many limitations that prevent genomic being applied in the clinical practice. In each patient, not all the lesions have been biopsied, and this is obviously not possible, but the genomic characterization of the patient was therefore partial. It is well known that there is a scarcity of cfDNA in the bloodstream during the initial remission phases of the disease, and this can lead to post-negative evaluations. The cfDNA release may also be conditioned by towards one different environment, so maybe different if we are dealing with a pulmonary disease or open lesions or bone marrow disease only. There is no standardization on positive cutoff in cfDNA measurement. There is a lack of post-therapy studies, and there is no evaluation of the correlation with SUV mass. Thus, for example, the patient with the lesion with a higher SUV mass carry worse genomic mutations or not. However, if this field of research will continue to grow, in the future, liquid biopsy and genomics may be used side by side with that for the prognostication therapy assessment. So far, these diseases are still immature for a clinical application. Let's move now very quickly to other topics that can bring some new information on the diagnosis of myeloma. The second topic is TG tracer. This takes origin from a very well-known background that is up to 11% of patients with active myeloma show a post-negative staging FTG band. 11% is a quite big number, and this is concerning, even though it's well known that the prognostic value is retained, although it's post-negative. So, comparing the FTG with Y, for example, we know that there are some regions that, for some reasons, do not become FTG at stage. And to reduce this amount of post-negativity, other traces are being like having level calling finally showing that we both significantly increased detection rate at staging as compared to FTG and comparable results to results to be wide. Actually, these traces are not widely employed in the clinical practice. One reason is because carbon-11 calling and carbon-11 timing can be produced in there is a lot of studies exploring the toxicity and actually their ability and capacity to assess barriers. To be cytotron independent, actually other traces could be ideally present, like for example, chloroquine tyrosine or bucycline. As you can see from these self-explaining pictures, both these traces seem to have the ability to detect more lesions as compared to antigen, but again, we are in the clinical situation where we don't know if they are particularly able to demonstrate correctly the cell response, as well as to understand which is the prognostic value of detecting one or few more lesions as compared to antigen. So actually, these traces, even though they are certainly effective, so far cannot be used in more interesting is the fact. The fact is that held out with anti-CD38 traces. It is important that those traces are generally labeled with a long half-life results, like for example, and they are particularly interesting because there are several drugs that have as a mechanism of uptake the CD38 labeling. So here you could very nice to predict the effective of the one, for example, or is it schema. We could use this kind of traces. This because we perfectly know that there are some patients that are resistant to the tuximab because of a primary resistance in terms of lack of expression of CD38 within multiple myeloma cells, and or acquired resistance because of down-regulation of the expression of this membrane receptor. So just to reduce toxicity, useless toxicity in the patient, it is possible to predict actually the efficacy of this drug by having the Let's move on to other traces, more interesting for their possible diagnostic approach. One is CXCR4. The imaging tracer is labeled with gallium, and this tracer targets the CXCR4 chemokine receptor 4. And this is a G protein coupled with calcium receptor family, indicating the process of cell migration as well as the homing process of an creating stem cells to bone marrow and genesis and cell migration. In pathological conditions, both control because it enhances cellular proliferation and migration of metastatic.
Thank you so much, Dr. Khanum. Thank you so much for your talk. Possibly we ran out of time to not finish by now. We can upload this talk on our website. Link to this section. So we can want to get we have some more questions. I will discuss it. Dr.
I have a very bad audio connection. If you have any question, can you please write it down in the chat, please, or in the questions area?
Whenever
question about your talk will type it if you have the audio connection.
Sorry, I just I have an unstable. Yeah, now I can
Yes,
hear.
thanks for letting us know. We'll type in the question for you if there's any.
Regarding Dr. Akif, your talk. Oh, yes. He's not available. It's not available in Pakistan.
Just no.
Acha. The whole thing is that we have the same problems. And that I remember one of the talk you remember as by Muhammad Umar in Multan.
Yeah.
And at that time, we were discussing the same challenges. And still, after such a era, we are in the same situation. What we have started is that particularly with RMI and Northwest is doing an MDTs, and that MDTs has reduced all these problems to a great extent. And that what I was also would like to first of all invite Indian people if they want to come on that MDTs, one thing, and then that your institution itself with the Khyber Teaching Hospital, LHM, and HMC can do the MDTs. And I'm really telling you,
whenever patients comes through the teaching hospitals, there we don't face such a problem. But when they come from the periphery, they have done partial surgeries, then we have to deal with all those patients. And well, at the teaching hospital level, we have MDTs with the KTH hospitals, with the Kuwait Teaching Hospital. We also run similar MDTs. But most of the time, the thyroid surgery is partially in like too little or too extensive surgeries being done already. So that was the issues that we wanted to discuss.
The issue that I'm much more focusing on is the pathology.
Yeah.
When we involve them in MDTs, they started to understand what our real questions are. And that's the Bethesda classification, as well as the way we want the FNAs to be done. And even we have asked them to repeat the sampling. And I personally feel this is making a difference. And that's the only way we can help at the moment to our patients.
Okay. Yes, I totally agree with you. Whenever the pathologists sit with us in other MDTs like JEPNETs or on colorectal CA, so we learn a lot from them and they learn a lot from us. So it's always a beneficial exercise to have an MDT at your premises. So we have some online participants. Some good presentations from me, yes, I know, and some from Fahim. So the last Dr. Hira is asking, my question is from Dr. Hajra, and clinical experience of completion of therapy cycles of radium 2 to 3 without development of grade 3 adverse effects and its impact on the overall survival.
So yes, that's what I presented really, that patients who had 5 or 6 cycles, they had overall survival of 18.5 months. But this was when we had reviewed, they may have lived longer, so it was very good. And was very little toxicity in about, I think it was about 1 or 2 patients had grade 3 toxicity. But toxicity, you have to remember that these are patients with infiltration of their bone marrow. So it's sometimes hard to gauge that it's actually the treatment or it is their own metastatic disease which is affecting the bone marrow. But overall, we found it to be very safe in our practice. Yeah, it's Dr.
Thank you. Sorry, it's for the anonymous attendee. I think she can hear me or he can hear me. This says basically shows availability for PSNM Pakistan Society, I think sessions, especially annual conferences. So Hajra, I think you can give them my email if they want to, but I would probably do a virtual one rather than traveling for 2 days from London to. So it will be a virtual talk. Thank you.
We had a very wonderful conference last month of PSNM in Rawalpindi. And as you said that you'll be seeing quite a lot of lutetium PSMA and other tumors as well. So we had the opportunity of listening to some talks regarding the treatment of glioblastoma multiforme with the lutetium-based PSMAs. So I'll conclude the discussion. And today's session, we had wonderful presentations from Dr. Fahim Al Hassan. And the first one was that on the lutetium PSMA, the New Horizons in castration-resistant metastatic prostate carcinoma, and we learned a lot from them. And in this presentation, he emphasized on the significant role and in the future prospects of lutetium-based PSMA in the management of CA prostate, and some new trials are coming up which will highlight its role. Mostly we nuclear physicians get the patients from the oncologist, which are really in a bad shape, and we are supposed to then do experimentation on them. And it was our discussion with John Buscombe in that 2005 and 6 when I worked with him at the Royal Free, and we were getting all those stage 4 cases which were all chemo resistant. So I think we should have now more of an emphasis on the early institution of radionuclide therapies, and those trials should be very much supported. The second presentation was that of Dr. Hajra Ilyas, and radium-223 is now a bit of a out of market thing because of PSMAs coming in and a lot of other beta emitters. Specific agents have come up, and these pain palliation is now supposed to be done by the PSMA now in the near future, what we expect. But these prototype beta and alpha emitter will stay for a long time in the near future as well in the management of pain, and as well as improving the patient's quality of life. The third presentation was mine. It was just a so-so presentation, so I'll just skip that. It was just on the policies, how we can improve on our services at our country. We did learn a lot from Dr. Fahim again on the SPECT CT, and it revealed that many of us are too naive to SPECT CTs, especially when it comes to musculoskeletal imaging. So we need to relearn and de-learn and relearn our SPECT CTs again, all those senior nuclear physicians. And for the new budding nuclear physicians and the trainees, I think they need to learn too much of a CT now as a nuclear physician as well, so to be competitive in the field of imaging and the hybrid imaging. And the last talk, which was from Italy, Bologna, by Cristina Anani. It was a wonderful presentation, though we had to cut it short because of the shortage of time, and we had some connection problems. So thank you all of you for your patient listening, and I'll call it a successful presentations and a successful session. Over to you, Dr. Hajra.
Thank you. I think we finished the session. Thank you.